Good evening, participants, and good evening to all of you. Today we have a guest speaker, Dr. Sushma Meda, and she is going to take a topic fetal growth restriction, diagnosis and the management, which made easy. So, before we go ahead with the webinars for today, I will give a little idea about our Shield Connect page. So, let me share a screen. So, this is our page shieldconnect.in. You can find various sections in our Shield Connect page. Like the first one is the blog, where you can find all the blogs related to various disease and recent topics like COVID and black fungus, written by eminent speakers and experts. Then we have a second section, webinar. So when you click on the upcoming webinars, you will be able to see the webinars which are going to be held in this month. When you click on the see more, you will be able to see our webinar video over here. You just have to register. And here in the comment section, participants, you can share your feedbacks and questions. So at the end, we can have a Q&A session with our speaker of the day. Then we have another page, awareness page. So we have three awareness page, like a immune booster page, where you can find our Rudiment new reintroduce product page, where you will find all the blogs and videos related to the respiratory immunity. Then there is second awareness page, PCOS awareness page, where you will able to get all the details regarding PCOS by various doctors in various languages like Tamil, Hindi, Telugu, Malayalam, English. Then recently we have launched a COVID-19 awareness page. You will get all the blogs and videos related to COVID. Then we have our leader page, where you can find all the speakers who are connected with the Shield Connect page. And then we have a special day pages. For example, if you go on Hypertension Day, World Hypertension Day, you will get all the videos related to the hypertension. So this is our page, Shield Connect. And let me give a little intro of our speaker for the day, Dr. Sushma Meda. Ma'am is MS in obstetric and gynecology. Ma'am is consultant obstetrician and gynecologist. Ma'am is certified by Fetal Medicine Foundation, FMF, UK for anti-scan, TIFA, fetal echo, Doppler. Ma'am is consultant in Sri Krishna Nursing Home in Nalgonda. So I welcome you, ma'am, on our platform for today's session. And I will hand over the session to you, ma'am. Thank you.
Good evening, everyone. Am I audible?
Yes, ma'am.
Okay, thank you. Thank you very much for that kind introduction. I'm very glad to be here on this pleasant evening. I must thank Shield Healthcare for providing me this opportunity. Today, my topic is fetal growth restriction, diagnosis and management made easy. We no longer call it IUGR because the word retardation in IUGR doesn't suit physically restricted fetuses. Traditionally, we have always learned fetal growth restriction as SGA fetuses, that is small for gestational fetuses with umbilical artery changes and ductus venosus changes. This is umbilical artery. This highest point is the systole and the lowest point is the diastole. This diastolic flow gradually reduces, becomes absent, and is even reversed. After that, that is followed by ductus venosus A-wave reversal. And if the fetus is not intervened here, it might lead to fetal death. So this is what we have learned traditionally regarding fetal growth restriction. But the newer guidelines that has come up, those are Barcelona guidelines, Delphi consensus, FIGO guidelines, and ISWOG guidelines. ISWOG guidelines has come up as late as in May 2021. So all these guidelines not only talk about these traditional fetuses which we consider as FGR, but also they include a wide variety of fetuses that do not have umbilical artery Doppler changes, that do not have ductus venosus changes, and that are not even small for gestational age. But those fetuses are considered fetal growth restricted fetuses, and if they are not intervened in time, they might lead to fetal death. So, why should we even learn these guidelines? We are already doing well with the previous guidelines, then why should we even learn these guidelines? Because it is to reduce intrauterine deaths and stillbirths in our antenatal clinics by using best possible and proven evidence-based methods. Why do we call them proven? Because the guideline Barcelona guidelines have come up in 2014, and since 7 years, fetal medicine centers across India are using these guidelines and have reduced their IUDs and stillbirths to bare minimum. So it is time all the gynecologists learn these guidelines, and this benefit is percolated to each and every antenatal patient in our clinics. So reducing IUDs, isn't this reason enough for all of us to learn these guidelines? Coming to causes of fetal growth restriction, though there are various causes of fetal growth restriction, placental insufficiency is the major cause of fetal growth restriction, contributing to more than 80% of causes. Other causes are chromosomal abnormalities, fetal structural abnormalities, fetal infections, and other maternal conditions. We are going to deal today on placental insufficiency, which is causing fetal growth restriction. By diagnosing these fetuses and managing them properly, we can reduce stillbirth rate and IUD rate. Definition. Before moving on to definition of FGR, we should first learn the definition of small for gestational age fetus. What is small for gestational age fetus? It is the fetal weight below the 10th percentile for that particular gestational age. For example, we take a particular gestational age fetus, we take 100 fetuses in a particular gestational age and keep them in the increasing order of their weights. The first 10 are called small for gestational age fetuses. Imagine these are fetuses, 27-week fetuses that are well dressed up for our webinar today. So the first 10 fetuses are considered small for gestation, whereas the last 10 fetuses are considered large for gestation. The remaining fetuses between 10 to 90, these are considered as average for gestational age. Now the definition of fetal growth restriction is, it is defined as failure to achieve the endorsed growth potential. So what is the endorsed growth potential and how do we identify those fetuses that has not achieved the endorsed growth potential? We are going to learn now. So the definition is based on the classification. Earlier classifications were symmetric and asymmetric fetal growth restrictions and also intrinsic and extrinsic fetal growth restrictions. But those classifications are no longer used now. The current classification that is recommended is early onset and late onset fetal growth restriction. Early onset means fetal growth restriction that occurs before 32 weeks, whereas late onset is fetal growth restriction that occurs after 32 weeks. And traditionally, whatever we are diagnosing fetal growth restricted fetuses using umbilical artery changes and ductus venosus changes, all these fall under early onset fetal growth restriction. Whereas late onset fetal growth restriction fetuses do not have umbilical artery changes and they do not have ductus venosus changes and they might not even be small for gestational age as well. So, but early onset fetal growth restrictions, they only contribute to 30% of FGRs, whereas late onset fetuses, fetal growth restrictions, they contribute to 70%. So that means by following the traditional way of diagnosis of fetal growth restriction, we are missing out on 70% of fetal growth restrictions. Today, we are going to learn how to diagnose late onset and how to manage both the classifications. So in early onset fetal growth restrictions, the placental damage is more than 30%. The placental damage is more than 30%. That's why growth restriction presents early on in fetal life and the fetus is very small. Whereas in late onset fetal growth restriction, placental damage is less than 30%. So until 32 weeks, the remaining placenta can give the sufficient nutritional needs to the fetus. So the fetus is not growth restricted until 32 weeks. So if the fetal growth restriction occurs too early, that is because of the placental damage. Higher the placental damage, earlier is the presentation of fetal growth restriction and it can present as early as during TICA scan. And the lower is the placental damage, it can present as late as even after 36 weeks. So all the presentation of fetal growth restriction depends exclusively on placental damage, on the amount of placenta damage. That's why Fetal Medicine Foundation and Society of Fetal Medicine in India recommends that at least 2 growth scans should be done in third trimester, one at 32 weeks to diagnose early onset fetal growth restriction and one at about 36 to 37 weeks to diagnose late onset fetal growth restriction. Now, definition of fetal growth restriction is elaborated based on early onset and based on late onset fetal growth restriction. Definitions completely differ. So we will deal with each one separately. Definition of early onset fetal growth restriction is if the fetus is less than third centile, then it is considered as fetal growth restriction. And there is something called as contributory, that is, if the fetus is less than third percentile with Doppler changes, those are uterine and umbilical artery Doppler changes, then it is considered early onset fetal growth restriction. So the fetus must be, if the fetus is completely below the third percentile, then definitely it is early onset fetal growth restriction. And if it is within the 10th centile with Doppler changes, then we have to consider it as early onset fetal growth restriction. Whereas if there is absent in diastolic flow, again it is considered as early onset fetal growth restriction. So what does this mean is, in the first 10 fetuses, the first 3 fetuses are definitely considered as fetal growth restricted fetuses. Whereas in the remaining fetuses, those fetuses which have Doppler changes, that is uterine and umbilical artery Doppler changes, are considered to be growth restricted. And the remaining fetuses are small for gestational fetuses without growth restriction. So they are normal small for growth restricted fetuses. What does that mean is they are normal small for growth restricted fetuses are meant to be here. Their genetic potential is low. Their family history, their hereditary, their genetic potential is made to be low. That means their parents have low BMI, low height, and that is why they are here, but not because of deficiency in nutrition. Whereas those fetuses with Doppler changes are here because of deficiency in nutrition. They are supposed to be here in the AGA group, but they are here because of the damaged placenta and deficiency in nutrition. Coming to late onset fetal growth restriction, even after 32 weeks, if a fetus falls under less than third centile, we consider it as late onset fetal growth restriction. Along with that, there are other contributory factors which can be diagnosed as late onset fetal growth restriction. That is, there must be at least 2 out of the following 3. One is if the estimated fetal weight is less than 10 centile and estimated fetal weight crossing 2 quartiles and Doppler changes, and among the Doppler changes, you can notice that umbilical artery changes are conspicuously absent. There is no umbilical artery changes happening within the late onset fetal growth restriction fetuses. So, if we consider only umbilical artery as the diagnostic criteria for Doppler changes to diagnose fetal growth restriction, then we will miss out on the late onset fetal growth restriction cases. And also, Here, estimated fetal weight less than 10 centiles is only an option. That means small for gestational age is only an option. The fetus cannot even be SDA, but still if the fetus crosses 2 quartiles or has Doppler changes, then it can be fetal growth restricted. So what is cerebroplacental ratio and why are we considered about it? Why are we even taking this into consideration and not umbilical artery, not middle cerebral artery, and not others? Because this study shows us that with advancing gestational age, when the fetus is growth restricted, umbilical artery Dopplers are more or less not changed, uterine artery Dopplers are more or less unchanged, and middle cerebral artery Dopplers, they are changed only after 36 weeks. So the first one to change is cerebroplacental ratio. This is the most sensitive marker to diagnose fetal growth restriction after 32 weeks. That is why we consider cerebroplacental ratio as diagnostic marker in late onset fetal growth restriction. So in the definition of late onset fetal growth restriction, apart from the Doppler changes, we also have this term called estimated fetal weight crossing more than 2 quartiles. What does it mean? That means 2 quartiles means 1 quartile is 25% and 2 quartiles is 50%. If the fetus weight falls for 50 quartiles, that means if it is initially in the 80th quartile and later on if it falls to 30th quartile, or if it is at 70 and falls to 20 quartiles, the percentile of the fetal weight, then it is considered significant and we have to consider it as fetal growth restriction. For example, in this, students are standing in line. They are standing in line from 5th grade to 10th grade, and these students are having more weight, whereas these students are having less weight. I mean, these students are actually standing according to height, but if the student standing here in her 5th class has come down to here and she has crossed 50 quartiles, that means there is some nutritional deficiency that has happened. That is because of that she has moved from 80th quartile to 30th quartile. So that is what means it is defining as a failure to achieve the endorsed growth potential. That fetuses which have the growth potential to get into 80th percentile, because of nutritional deficiency, if they come into 30th percentile, they are considered as fetal growth restricted. So even average for gestational age fetuses, that means fetuses falling between 10th to 90th centile, also can be fetal growth restricted. So this study shows that it deals with stillbirth rates during antenatal period, and it shows that the fetuses below the 3rd percentile have highest perinatal mortality. So that is why fetuses less than 3rd percentile, irrespective of Doppler changes, are considered fetal growth restricted. Whereas even if they are less than 10%, some of the fetuses can have high perinatal mortality if there are Doppler changes. And when do we have least perinatal mortality? It is only after 50th percentile, between 50 to 80, 90 percentiles, perinatal mortality is low. That means even between 10th to 50th percentile, there are certain fetuses which are growth restricted. These fetuses, few of them are meant to be in the above 80th or 50th percentiles, but because of nutritional deficiency happening, they are here. But they are not below the 10th centile because the growth restriction started happening later on. This is one more study which shows that below the 3rd percentile, perinatal mortality is too high. and the perinatal mortality comes down only at 80th percentile. So the best percentile is not 50, as we have always traditionally thought that middle person, the one standing at 50 is the best. No, the one standing at 80 is the best of all. Between 50 to 90 are the people who are having least perinatal mortality. Even those between 10 and 50 still have significant mortality risk. Not all of them, but few of them with Doppler changes are to be marked and are to be followed, and they are put under surveillance. So in early onset fetal growth restriction, it represents 20 to 30% of fetal growth restriction cases, and it is associated with gestational hypertension. As we all know, gestational hypertension has placental damage because of poor invasion of cytotrophoblastic cells into the spiral arterioles. So there is placental insufficiency in gestational hypertension, and the same problem is for early onset fetal growth restriction. That's why they are closely associated. Whereas in late onset fetal growth restriction, it is not very much associated with hypertensive disorders of pregnancy. Differences between early and late onset fetal growth restrictions. The problem in early onset fetal growth restriction is management. Why? Because it is a very small fetus that is below 32 weeks, the weight is less, and also lung maturity is not attained. So that is the reason management is very difficult. Whereas in late onset fetal growth restriction, management is not difficult, but because the fetus has crossed 32 weeks and it has attained certain level of lung maturity. But the problem is with diagnosis. Why? Because traditionally we have not included these diagnostic criteria, and we are not well versed with the diagnostic criteria of late onset fetal growth restriction. But today with this talk, all of us are going to learn the diagnostic criteria of late onset fetal growth restriction and save our growth restricted babies from stillbirths. And that is going to be a victory for all of us. And considering the fetal size, in early onset fetal growth restriction, fetus is very small, and in late onset, it is not necessarily small. Placental disease, it is high, more than 30%. In late, it is low, less than 30%. Abnormal umbilical artery, this is very significant change. Abnormal umbilical artery is seen in early onset fetal growth restriction, but it is not seen in late onset fetal growth restriction. Preeclampsia is more frequently associated with early onset, but not much with late onset. Hypoxia. Hypoxia is more in early onset fetal growth restrictions because placental damage is more. So placenta not only supplies nutrition to the fetus, but also supplies oxygen. So oxygen delivery to the fetus is also reduced. Whereas here it is not much. But tolerance to hypoxia is very good in these fetuses. Tolerance to hypoxia is poor in late onset fetal growth restricted fetuses. Because late onset fetal growth restricted fetuses are very sensitive to hypoxia. Though the hypoxia is very less, even to the less hypoxia, fetus can succumb in utero. This is a study that shows that with advancing gestational age, the respiratory demands and the fetal nutritional demands, how do they differ? Nutritional demands are always continuously increasing. So when there is placental damage early in fetal life, nutritional demands are not met and the fetus is growth restricted. Whereas respiratory demands, they are not high initially. So the fetus does not succumb to hypoxia. Even if there is hypoxia, fetus will not die. The fetuses in early onset hypoxia will not die due to hypoxia, but they die due to acidosis. Whereas Late onset fetal growth restricted fetuses, they die because of hypoxia. Even minute amounts of hypoxia, these fetuses might succumb. So what are the tools we have for diagnosing and also for surveillance and for managing these fetuses with fetal growth restriction? The tools we have are Dopplers and AFI. AFI, though we obstetricians consider it as very significant, it is not of much use in either diagnosing or in managing and deciding when to deliver the fetus. Whereas NST, daily fetal peak count, and biophysical profile are important. We'll deal with each of them one by one. First, going to Dopplers. This is uterine artery Doppler. Uterine artery Doppler has high resistance flow initially, but with advancing gestational age, because of spiral artery invasion by cytotrophoblastic cells, there is increased diastolic flow in the uterine artery. If this doesn't happen, the uterine notching and the high resistance still persists later on into the second and third trimester, then the fetus is considered growth restricted. Umbilical arteries, all of us know that umbilical arteries transforms from normal umbilical artery to reduced end diastolic flow to absent to reversal. But when does this happen? These changes happen, the first change happens only when there is 30% damage to the placenta. So if it is less than 30% damage, the umbilical artery diastolic flow still remains normal. Only after 30% damage, umbilical artery and diastolic flow reduces. So this is the major difference why we have classified fetuses into early onset and late onset fetal growth restricted fetuses based on placental damage of 30%. In late onset fetal growth restricted fetuses, the placental damage is less than 30%. So umbilical artery and diastolic flow is not changed. So we cannot diagnose those fetuses following the umbilical artery alone. And if the damage is increasing, the changes are even increasing. Middle cerebral artery. In middle cerebral artery Dopplers, there is high resistance flow always throughout the gestation. If there is hypoxia, that means if the umbilical artery, if the placenta is damaged and if the umbilical artery there is reduced end diastolic flow, there are compensatory changes happening in the middle cerebral artery that causes the redistribution of blood into the important organs. Fetus tries to increase blood supply to the important organs like brain, heart, and adrenals. So these three organs, diastolic flow increases because there is hypoxia. Ductus venosus, if changes occur in ductus venosus, that is very ominous. As soon as ductus venosus Doppler changes are noticed, the baby should be delivered as quickly as possible. Either it be reduced A wave or reversal of A wave. If there is high resistance here or if there is reversal, whatever it is, it indicates that fetus is probably going into acidosis. That indicates that the fetus has to be delivered immediately. That is as early as possible. What is cerebroplacental ratio? Cerebroplacental ratio is the ratio of PI of middle cerebral artery to the PI of umbilical artery. As we have seen before, middle cerebral artery PI is always high resistance flow unless there is redistribution. Whereas umbilical artery PI, That means resistance in umbilical artery should always be low. If this alters, the first thing to change is the ratio between those two. Even though umbilical artery looks normal, even though MCA looks seemingly normal, even then, if we take the ratio, but the ratio is the first thing to get abnormal. So that is why we have to consider cerebroplacental ratio in diagnosing late onset fetal growth restriction. Next tool we have in diagnosing, apart from Doppler, is fetal growth velocity. What is growth and what is growth velocity? Growth is, if you take estimated fetal weight at that particular gestational age, it is growth. Growth velocity is when you compare it with the previous scan, its estimated fetal weight, that is called fetal growth velocity. That is done by using these percentile charts. So if we consider this fetus in the first graph, at 34 weeks, it is considered to be small for gestational age. But if we compare it with the earlier scans, all the while this fetus was constantly in the small for gestational age. That means that this fetus is growing at SDA as SDA since the beginning. That means this fetus might be genetically predetermined to be small and there are no Doppler changes, then we need not worry regarding this fetus. Whereas in the second fetus, at 30 weeks, there is growth. The fetus is small. So should we label it as small for gestational age or should we label it as fetal growth restriction? That only depends on the previous two scan findings. In the previous two scan findings, even though initially it is small, later on it is becoming smaller and smaller. That means this fetus is growth restricted. We will take few more examples taking growth velocity curves. In this graph, we are taking BPD, HC, AC and FL individually. In this fetus, all of them are going from AGA to SDA. This is significant. So this fetus might be going in for growth restriction and it has to be monitored. This fetus, initially it was in the average for gestation age group and it has fallen into SDA group. This is also significant. Here we have 4 different fetuses plotted on graphs with their abdominal circumference. In the first fetus, initially it was in AGA and gradually it was going into SDA. So this fetus is FGR fetus. Whereas the second one, all the while it is at the border of going into SDA. So this is the genetic potential of the fetus and it is not going up or down. So regarding these fetuses, we need not be worried and we need not increase surveillance. This fetus, even though at the end, it is average for gestational age. This in the third graph, the fetus at 34 weeks, it is at average for gestational age. But initially it was large for gestational age. So this fetus has potential to be large. But because of nutritional deficiency, because of placental insufficiency, it is moving on to falling into AGA. So this fall is significant. Even though this fetus is not small for gestational age, we have to consider this fetus as growth restricted. And this fourth fetus, if we take it, all the while it is in average for gestational age. Now, if we compare third and fourth fetuses, the last scans, both of them are at same abdominal circumferences. But the fourth fetus is not growth restricted, whereas the third fetus is growth restricted. We can come into these conclusions only by doing these growth velocity charts. Next, NSC. We as obstetricians are very familiar with NSTs. There is a lot to talk about NSTs, but in fetal growth restricted fetuses, the two important points to consider are variability and deceleration. If there is loss of variability and there is unprovoked late deceleration, that means it is an ominous sign and the fetus has to be delivered as soon as possible. So far we have learned that the ominous signs are ductus venosus changes and NST decelerations. Coming to A5, though we get panicky when there is low A5, yes, it is an indicator of hypoxia, but it does not give us any clue on when to deliver because there is no consensus on how low is too low to deliver. That is, even if A5 is 3 or 4, if the Dopplers are normal, and if the daily NSTs are normal, and if the daily fetal peak count is normal, we can continue the pregnancy. That is what the guidelines are saying. So, if A5 is low, admit the patient, do daily fetal peak count, do daily NSTs, and do Dopplers regularly on frequent intervals and see and continue the pregnancy and drag on the pregnancy as much as possible because even 1 day, even 2 days of continuing the pregnancy intrauterine reduces perinatal mortality and morbidity. A5 is low means it is not that we have to leave it completely as it is not a significant marker, but we have to monitor it, but not be in a hurry to deliver it. Coming to biophysical profile, in biophysical profile we have breathing movement, tone, fetal movement, A5 and NST. So we have already seen that NST is very important and AFI is not very significant. Though it is important, it is not very significant to consider when to deliver. Whereas breathing movements is the most important. If breathing movements is seen in a fetus, then it is very reassuring. Daily fetal peak count. We have all been traditionally following daily fetal peak count, but this paper, which has come recently, has shown the importance of daily fetal peak count, and it has reinforced our belief in daily fetal peak count. This paper shows that reduced fetal movements is experienced by 55% of women before stillbirth, and it is preceded by 3 to 4 days before stillbirth. So, at least in half of the women going to have stillbirth, they can detect it 3 to 4 days ahead. And what is the number? There is no fixed number. We actually take 12 as the minimum count for every fetus, but each fetus has its own pattern, and that is what we have to learn to recognize. As in Doppler changes, as in AG and SGA fetuses, each fetus has its own growth potential. The same way, each fetus has its own movement pattern. And who is the best person to know that the fetus is moving less? The mother. So trust the mother, and if there are greater than 2 episodes of reduced fetal movements, then we have to put her on high risk surveillance. How do we manage? To be honest, there is not much to be done with management of fetal growth restricted fetuses except to learn and to know when to deliver the baby. So knowing when to deliver the baby itself is what we can do. No modality of treatment is proven to be effective in treating fetal growth restricted fetuses except that we have to deliver the baby in time, not too early so that causing iatrogenic prematurity, not too late causing IUDs or significant morbidity and mortality. So this management is significantly is significantly important to diagnose and to know when to deliver the baby. So though we have various modalities like giving L-arginine, high protein diet, sildenafil, and antioxidants, none of them have proven to be beneficial. Though we can continue giving L-arginine, high protein diet, and antioxidants, sildenafil is the one which is having controversial studies. In sildenafil, the recent study shows us that the babies which have been treated while they are intrauterine with sildenafil, they have significant postnatal hemorrhage episodes. So the study is intermittently and immediately banned from continuing because of this finding. So sildenafil should not be considered, whereas other high protein diets can be considered. There are other potential targets for therapy, but these are still under study. Aspirin 150 mg. Aspirin trial conducted by Fetal Medicine Foundation UK has proved beyond doubt that aspirin 150 mg is beneficial to prevent preeclampsia. But there is no study so far to prove that aspirin 150 is beneficial in preventing FGR. So, though we give aspirin 150 mg in high-risk cases to prevent preeclampsia, we are not sure if it helps in preventing FGR or if it does not help. But we must definitely give aspirin 150 mg when we diagnose high-risk cases and when we have uh, uterine artery PI abnormalities at NT scan. We have to give aspirin 150 mg and it helps drastically reduce the incidence of preeclampsia. Now, there is staging of fetal growth restriction and management completely depends on staging. This slide appears complicated, but I will try to simplify it. The staging depends on the Doppler changes itself. So in staging, to simplify, stage 1 is reduced end-diastolic flow, stage 2 is absent end-diastolic flow, stage 3 is reverse end-diastolic flow, and stage 4 is ductus venosus reversal. So far it sounds good. This is simple. Then ductus venosus, even though it is not reversed, if the PI is high, it is considered stage 3. And one more ominous thing that I have told you earlier is decelerations on NST. That is also stage 4. In these 4 stages, stage 1 and 2, we can wait. We need not deliver them immediately. So this is what I want to stress today, that if at all you see reduced end-diastolic flow, and if at all you see a patient with absent end-diastolic flow, don't be in a hurry to deliver the babies. Yes, put them on strict surveillance, do daily NSTs, do fetal kick counts, and do Dopplers depending on the stages. But it is not a sign for, it is not an indication for immediate delivery. Whereas in stage 3 and 4, with reversal of end-diastolic flow, with ductus venosus changes, and late decelerations on NST, these are ominous signs and you have to deliver the baby immediately by giving betnazole. So how frequently do you monitor these babies with stage 1 and stage 2? And now before that, so what about all other Doppler changes like middle cerebral artery changes, uterine artery changes, and cerebroplacental ratio? All those are milder variants, so they come under stage 1. Only ductus venosus changes, reversal of changes, reversal of end-diastolic flow and late deceleration are considered ominous. So how do we monitor these babies? Stage 1, we have to do weekly monitoring until the fetus goes till 37 weeks. So we need not be in a hurry to deliver the baby, but there is a caution as long as NSTs are normal and as long as ductus venosus is normal, we can do weekly monitoring and continue the pregnancy till 37 weeks. In stage 2, even when there is absent and diastolic flow, we need not deliver them in a hurry, but we have to do bi-weekly Dopplers. That means twice a week we have to do Dopplers along with daily NSTs, and we can continue the pregnancy till 34 weeks. If the NST is normal, if the daily fetal kit count perceived by the mother is normal, and if the Dopplers are not decreasing, like not falling into these two stages, then we can continue this pregnancy till 34 weeks. And in stage 3 and stage 4, we have to deliver them as early as possible. We only have 1 to 2 days time in stage 3 and 12 hours time in stage 4. And before that, we have to give betnazole and deliver them at least by 30 or 26 weeks. Why do we take 26 weeks? Because our NICUs can only handle babies after 26 to 27 weeks. And what if there is reversal before 26 weeks? There is no, that means we cannot let the baby continue and we cannot help it even if we deliver it. So this is to sum up both the slides. In stage 1, we have all these features like estimated fetal weight less than third, PPR changes, umbilical artery changes, middle cerebral artery changes, and uterine artery changes. For these babies, we have to do weekly monitoring and deliver them at 37 weeks, and we can even do induction of labor is what the guidelines say. So the induction of labor should not be with misoprostol or prostaglandins, but it should be only mechanical induction, and also there should be continuous surveillance. Normally, in any labor, we do intermittent fetal heart rate monitoring, but in these high-risk cases, we have to do continuous fetal heart rate monitoring, and we can let them go in for normal vaginal delivery if it is going in time, but we should have a low cutoff, and whenever we suspect anything, we can take them up for emergency sections. Whereas in the stage 2, stage 3, and stage 4, cesarean section is the modality of delivery. In stage 2, with absent and diastolic flow, we do bi-weekly surveillance and deliver the baby at 34 weeks by cesarean section. So we can wait till 34 weeks even if there is absent and diastolic flow, provided, I stress upon this, provided NST is normal and ductus venosus is normal and daily fetal movement count is normal. Whereas when you diagnose it as stage 3 and 4, either with reversal or with ductus venosus changes or with fetal heart rate decelerations, we have to do cesarean section B, even if it is a 30 weeks or 26 weeks. So this is the sum up of today's talk. Thank you very much for this patient listening.
Thank you so much, ma'am, for giving information regarding IUGR. So let's see if we have any question in the comment section. Okay, so Dr. Shalini Padmana wants to know a clear and simple explanation of FGR and SGA.
Okay, thank you for that.
So, simple explanation of fetal growth restriction. Okay, let it be. We will go to the next question. It is how accurate are ultrasound fetal weight?
Okay, how accurate is the ultrasound fetal weight?
Yes.
Okay, that is the question. How accurate is it?
Yes.
Accuracy of the fetal weight, estimated fetal weight, depends on the performing sonologist, and the accuracy will be higher at smaller gestational ages. That means we always give plus or minus 200 grams, 100 grams. So that variation is smaller
Mhm.
when it is in smaller gestational ages, like at 20 weeks, at 30 weeks, the variation will be small. As we advance to the higher gestation ages, with a good phonologist, accuracy should not, I mean, the variation should not be more than 300 grams or so. It can be till 500 grams is acceptable, but the variation will be less as the expertise increases. And also, in oligohydramnios cases, because of fetal compression, abdomen is compressed, so abdominal circumference cannot be taken well. And in that scenarios, maybe there might be some more variation.
Then another question is, what are the health problems that babies faces due to IUGR after the birth?
Okay, so it depends on when we deliver. If we deliver too late,
Mhm.
that is after the acidosis has set in, after there are irreversible changes in the fetus, then the fetus will have a lifelong morbidity. The fetus will be asphyxiated, fetus can have cerebral palsy and have mental retardation, and there can be lifelong morbidity. They can have neonatal convulsions and all. But if we deliver in right time, the mortality and morbidity is very less. And
And
also, there are uh, long-term issues with fetal growth restricted fetuses. Those long-term issues can be, those are diabetes, hypertension. These growth restricted fetuses are more prone for lifestyle disorders. And this can be prevented by giving DHA in the neonatal period.
And third question is like, as you mentioned, ma'am, that L-arginine is
Sorry,
also
sorry.
L-arginine
Okay.
is useful in the treatment of IUGR. So whether L-leucine can be also used for this treatment?
Whether what?
Another amino acid, L-leucine. Leucine.
Okay. I'm not sure of that. Even L-arginine is not proven to be beneficial. I mean,
Oh.
the studies, these are only given on an empirical basis, but they have
Mhm.
not proven to be beneficial. But the concept behind giving these is L-arginine is releases nitric oxide, which is a
Okay.
vasodilator, and
Okay.
it might help in increasing the placental perfusion. But these
Okay.
are only hypotheses that we are using. This is the hypothesis based on which we are using elargine. But still, on all the studies that have been conducted so far, elargine is not proven to be of much use.
So thank you so much for giving all the answers and information to the questions, ma'am. And we are glad to have you on this platform, and we would like to have more sessions with you in future on Shri Connect. And I also thank the participants to join for today's webinar. Thank you so much. And I also thank our Shield Connect colleagues, Stavan and Ambati Yakai, to make this webinar possible with you, ma'am. Thank you so much, ma'am.
Thank you very much, and thank you very much, Connect, and thank you very much, all the audience, for listening patiently to all the talks. And hopefully, all of us together can reduce stillbirth rate. Thank you.